I see we have Dr. Yancy has joined us, so perfect timing there. We just heard a great talk from Monica on really looking at how we can drive medical leadership to act now on anti-racism. And we're delighted that our next speaker will be Dr. Clyde Yancy, who's the Chief of Cardiology and the Magerstadt Professor of Medicine at Northwestern University, Feinberg School of Medicine. He's also the Vice Dean of Diversity and Inclusion. And just personally for me, Clyde is one of those people I hear and I'm always inspired and always have a new idea. And in fact, when he mentioned this point about equity as a new metric of professionalism on a recent webinar, I knew it was just ideal for this summit. So with that, delighted to turn the podium over to Dr. Yancy.
Well, Helen, thank you. The warmth of that introduction really is a testament to the rapport that we've developed over just a few short months. It really has been a joy to work with you, get to know you, and to also learn from you. So it's been a bidirectional learning experience, and what a privilege to be on an agenda with people that are thinking in such deep and insightful ways about how we can emerge as something different than what we were before. I always have anxiety when I hear people talk about returning back to normal, because I don't think where we were before was normal. It may have been normative, but it wasn't normal because it wasn't the kind of playing field that provided reasonable opportunity for everyone. The idea of a leadership summit on equity and anti-racism is not just provocative, it's revolutionary. Because what we're saying is that now is the time, under the auspices of CMSS, to really think about how we get leaders to think about the importance of equity and anti-racism. And I'm delighted that Helen embraced this narrative that we've been evolving over some time, addressing equity as a new metric of professionalism. And I'd like to spend the next 35 or 40 minutes engaging you in a thought process, not lecturing to you, but sharing thoughts with you and hoping that you are similarly having thoughts about how this really matters and what is the takeaway here and how can we think about a different kind of professionalism. So let's begin. I have no relevant disclosures for any of this content, but I do have personal disclosures that I think are important. I am before you as an underrepresented minority professional, physician, leader even. I think that narrows the field and makes me one of a few, not one of many. But my presence here with you almost didn't occur. It almost didn't occur because I come from a very poor community in the Deep South. Checking the median household income just 2 years ago, it still falls at or below the poverty line. I come before you and almost didn't make it because I am from functionally a single parent household. I am a product of segregated schools, born in 1958, acculturated in Louisiana. All of my education through high school was deeply segregated, even participatory sports, deeply segregated, even neighborhood and lifestyle, using different city bus services, deeply segregated. I still have vivid recall of personal encounters with the KKK. That is a firsthand experience that remains emblazoned in my consciousness and in my memory. I stand before you because I am one of those many, many people who had a lived experience that involved all of these characteristics that we read about, that we see in old magazines and old newspapers. Yet this was my experience: to drink from colored fountains, to eat meals in the kitchen of restaurants, to be falsely accused. And then once I emerged with this dream that I want to be a physician, legions of people said, stop it. It will never happen. It will never happen. But because of a strong-willed mother, and only because of that, I persevered. I went to historically Black College and University, Southern University in Baton Rouge, but I had no resources once I gained admission to medical school and had to literally pass the collection plate amongst my family to get the $800 to hold my place at Tulane, and then got there and had no meaningful way to pay for my education. until a Jack Aaron scholarship emerged. I pay homage to this because Mr. Aaron made his fortune on the commerce of coffee. Coffee would come in from the Caribbean to New Orleans, Port Town, be unloaded, and then redistributed for retail sale. And as my mother was a young girl living in New Orleans, trying to amass enough resources to go to Southern for college, she worked in coffee shipping, likely for Mr. Aaron. So it's a full circle acknowledgement that the woman who was responsible for my dream staying alive also touched bases with an entity that provided the financial support for me to go to medical school. And then my initial clinical exposure was Charity Hospital of New Orleans. I think Bill McDade is a part of this, and he has familiarity with healthcare in New Orleans, and he will very quickly tell you, this is one of the legacy safety net hospitals. And when I was there in 1978 as a first-year medical student, it was structurally segregated. So everything on one side was the mirror image of everything on the other side. Now, why do I take you through this very personal story and use this as a backdrop to talk about equity? Because I'm sharing with you what the broad context is for life in the United States, how experiences evolve, and how cultural set points are derived, and particularly when it's in reference to an underrepresented minority, all of the different circumstances that color that experience. But I think the better way to think about this is the brilliant poetry we heard at the inauguration. And I'm just sharing with you selected items from that poem, but I've underlined what I really want to make emphasis about. In this poem by Amanda Gorman and Hillary Klein, she emphasized we braved the belly of the beast. Beast might as well be plural. It wasn't just COVID-19. It was social injustice. It was racism. It was a long-standing effect of all of the examples and inequities that came to a head in 2020. And then she closed with the norms and notions of what just isn't always justice. And so I think that as we begin to use this to more nuance our perspective, adding that to the personal stories I've shared with you, we come up with these approaches that we'd like to accomplish again over the next 30 to 35 minutes. How do we get here? Why this focus on equity? What is it about the history of race in medicine that makes us appreciate how inequities might occur, and then go right into COVID-19 briefly about how it makes the case for apparent health inequity, and then understanding as best we can what might be a root cause for that health inequity, thinking about structural racism, a highly contentious issue in our contemporary vernacular, but I will not step aside from this because it's so important to have this narrative and appreciate that a scholarly thought process about what structural racism is provides a platform to understand some of the ever-present health inequities that we're addressing now. And then to appreciate this very important intersectionality. It's not just racism. It's not just bias, implicit or explicit. And it's not just equity. There's an intersectionality here that we have to appreciate. And as we appreciate this intersectionality and these definitions, we think about the principles of professionalism. This is the high point that I want to get to, because particularly for leaders, for physicians, for investigators, for scientists, we really embrace the notion that we are professionals. But what are those principles of professionalism, and do they include or are they lacking in equity as an explicit characteristic, and then move into a new view of professionalism, incorporating equity and literally how we might do that. So let's start with a short primer of the history of race in medicine. Let me be very clear. If I don't articulate something that makes one or more of us in the audience feel a little bit unsettled, then I haven't done my job. Because there are statements, narratives in the history of society and in the history of medicine that pertain directly to whether or not life as we know it is equitable or is evidence of inequity. So let's begin. When we think about the events that qualify as the history of medicine, and this is not meant to be exhaustive, but it is meant to be expository. Pulmonary function testing at its origin at its origin was adjusted to support the notion of slavery and was archived as early as the 19th century as a means to validate that, in fact, there is a difference in the lung function of the Negro without any science to satisfy that hypothesis. Even today, if you obtain pulmonary function testing, there is an algorithm that automatically executes a race adjustment for which there is no science. Mississippi appendectomies. I've hyperlinked a relevant reference here because this is difficult to articulate and difficult to hear. But women living in Mississippi in the 50s would be taken to hospital facilities for the purposes of an appendectomy, but instead to perform surgical sterilization without consent, without transparency. What about the Flexner report? I and many other academic physicians embraced the Flexner report because it was the fundamental pivot that said this is a way that we can make the education of physicians much more scientific, much more standardized. We can execute some requirements that will elevate the field. But in the process of evaluating the prevailing medical schools in the first decade of the 20th century, a report generated in 1910 to the Carnegie Foundation by Flexner overtly removed, or if you will, dismissed the majority of minority serving medical schools, with the exception of then two, now there are four because two have emerged, but dismissed those schools. But it was Flexner's assertion that students of color interested in healthcare would be better served in careers of hygiene, not in careers as a provider. We all know about the Tuskegee experience, but what we don't appreciate is that up until just one decade ago, there were descendants, direct descendants, spouses of the men involved in the Tuskegee experience that were still alive and had firsthand account of 40 years of human experimentation that was sanctioned by our government. When you recognize that there are many people living today with near-term recall of this, you can understand the mistrust that exists. And then who doesn't know about the HeLa cells and the Immortal Life of Henrietta Lacks was recorded by Rebecca Skloot, and an incredible story. I have the privilege of working with the Lacks Foundation now to redirect philanthropic resources to support Henrietta Lacks descendants. And through my several years of service at the NIH, I served as chair of the HeLa Cell Task Force, overseeing the way in which those cells were used. So this is a history of medicine that is important. If we go back to the first mention of race in medicine, it's 1790 by a physician at Penn who was an avowed abolitionist, but his approach to abolitionist was to try to qualify Blackness as a perturbation of normal being whiteness, and determine that it was a kind of leprosy. Several decades later, as gynecology was moving into a more formative specialty, the original surgical techniques, again, difficult to articulate in here, evolved from experimenting on enslaved women in Alabama without the benefit of anesthesia during those procedures. Think about 1857, when the notion was again made to qualify slavery based on a perturbation of physiology. And in post-Civil War, by law, persons of color were excluded from most social circumstances, including healthcare and research. And it wasn't until 1999 when the Human Genome Project made it definitive: there is no biological basis for race. No biological basis for race. I want you to pay attention to this quote. It reads thusly: "The wrongs which we seek to condemn and punish have been so calculated, so malignant, and so devastating that civilization cannot tolerate their being ignored because it cannot survive their being repeated." Arguably, everything that I've just shared with you is justifiably in this category. But yet, as we go through this thought process, this wasn't about the wrongs that were inflicted upon persons of color. This, in fact, was a quote from the Nuremberg experience from the opening statement made by the chief prosecutor, Robert Jackson. So think about the atrocities of World War II. Think about the centuries of atrocities for the then enslavement of Africans, and you begin to understand the depth to which the set point was established, looking at a difference between individuals as a function of race. So if that is the set point, and if that is the way in which inequities have emerged and are persistent in ways that I've briefly outlined to you, what happens in a real world experience when equity is absent? Well, this is what happens. Coronavirus, COVID-19 deaths by race and ethnicity in the United States. I frequently subscribe to the American Public Media Research Lab website. They do a very nice job of aggregating events, deaths from COVID-19 by race and ethnicity. This frequent visit was just this particular week. The data current through March 2nd. In purple, I've highlighted something for you that is so incredibly sobering. Let's be very clear. The burden of COVID-19 has been sobering for the entire country. But what it tells us is that for Black Americans, 1 out of every 555 Black Americans is now dead due to COVID-19. It's even worse for Indigenous Americans. 1 out of every 390 now dead due to COVID-19. But the burden is real for white Americans. The burden is real for Latinos. So this has been a scourge, but it's been experienced disproportionately. Now, as we think about this, can we learn anything from that disproportionality? And I think we can. I think this is a crisis point. I put this in writing. And in particular, there's a lot of science that I commented on in this particular piece. But the most important point was that this was it. This was the bellwether event that really exposed the extent to which we have healthcare disparities. So if that is the case, then we need to think about root cause. Yes, differences as a function of race. And many have argued maybe it's because of concomitant comorbidities. Maybe it's because of lifestyle decisions. Certainly not because of biology. Maybe there's another reason. This time, we're not talking about health inequity. We're talking about community level inequity. And I hope that I can have everyone's attention engaged because I'm going to share with you a very intriguing thought process. How do you actually balance risk between communities? Is there a way to do this? There is. The reference I showed you that I entered into the medical literature describing COVID-19 in African Americans relied heavily on observations here in Chicago, specifically that there was a fourfold greater likelihood of death due to COVID-19 in Blacks and African Americans than anyone else. And that risk of death was almost explicitly restricted to just 5 neighborhoods in the city's South Side. When you see those data and bring those data into a narrative, you begin to understand that maybe it's not race as much as it is place that is responsible for this vulnerability. Well, you can measure vulnerability. The US Census makes this easy by aggregating 15 US Census variables at the tract level that are required every time a census is completed. We've just been through one, and reports it as a social vulnerability index. If the score is 0, it means high resiliency, lowest vulnerability. If the score is 1, highest vulnerability, lowest resilience. So here I am this afternoon, sitting in Streeterville, Chicago. Cursor identifies correctly where I'm located. If we do the thought experiment with the social vulnerability indexes and apply it to Streeterville, this is downtown Chicago, the number is incredibly close to 0, lowest vulnerability, highest resilience. 10 miles later, you can expect to see this. The same exercise shows that the social vulnerability index is near 1, highest vulnerability, lowest resilience, where it is infamously known as the South Side, and it's just 10 miles away from where I'm seated. Why am I sharing this with you? Because now let's go back and think about those areas that we articulated in writing that reflected the concentration of COVID mortality. There's several zip codes. They're highlighted here in dark orange. These are the COVID-19 cases by zip code, some on the west side, communities that are frequented by persons of Latino ethnicity. Let's then overlay the social vulnerability index. The pattern is not surprising. It exactly mirrors the South Side communities with the highest concentration of COVID deaths and the West Side communities. But let's continue this thought experiment. Let's now look at the combination of fatalities in green and the risk scores in orange. This hypothesis now becomes a thesis because it argues that there's something unique about the vulnerability due to place that placed individuals not only at risk of infection, but this associated concomitant tragedy of death. We have been really troubled by all the observations and have tried to be very careful about how we use race in these sorts of analyses because it is a potent word, it's a volatile word. And in early calendar year 2021, we try to make a statement about the best way to use race in these kinds of analysis and argue that the most permissible way is when we're using race for the express purpose of identifying health inequities and identifying systemic racism. We also indicated in yet another report that understand the question being raised. If it's a question about biology that relates to genetic underpinnings, then use more sophisticated genetic markers that are available. If it's a question about the social construct, then use tools like the Social Vulnerability Index to make those descriptions, but really think carefully about how we use race. So if we bring all of this together, and we know how important this narrative is in today's world, what is structural racism? I made reference to it twice now. It's a system in which public policies, institutional practices, cultural representations, and other norms work in various, often reinforcing ways to perpetuate racial group inequity. It's not calling any person a racist. It's identifying the fact that there's something about the structure of our systems that were created by people that disqualify or discount one group over another. But I think this comment by C.S. Lewis is going to give all of us a little bit of heartburn, but it's worth hearing. The greatest evil is not done in those sordid dens that Dickens loved to paint, but is conceived and ordered, moved, seconded, carried, and minuted in clear, carpeted, warmed, well-lighted offices by quiet men with white collars and cut fingernails and smooth shaven cheeks who do not need to raise their voices. Kind of paints a picture which, in parallel with this definition of structural racism, lets you understand why this is so pernicious, why this is so durable in our system, because it's hard to deconstruct this kind of a system. So let me bring this back in line with what we saw here in Chicago. Many of you may not know what this acronym stands for, but HOLC was a Homeowner Loan Corporation. This was part of the New Deal back in the 1930s. And it was intended to identify the credit worthiness of different communities. There was a housing shortage after World War II. The intent was to spur housing development by offering federally backed mortgages. But part of the risk score incorporated principles of segregation. And so communities with uncertain credit worthiness that were home to a disproportionate representation of minorities received a D grade. And the D grade communities were outlined with red lines, thus the nomenclature red line. The adjacent communities, the C communities, were outlined with yellow lines. They were a bit more credit worthy, but their demographics might have been different. Stay with me on this, because now if we look at the original map from HOLC of Chicago, I've depicted it here. The areas in white, again, reflect where I'm sitting now, Streeterville, Chicago Gold Coast, downtown Chicago. Keep that image in mind and look at this statement. You see the red lines and you see the yellow lines. Well, you would think that persons living in the red lines that couldn't get the mortgages would just simply go to the adjacent community called islands for this experiment, where it was more accessible to get a federally backed mortgage. And you would think that the population shifts would follow suit, but that didn't happen. When you look at the gap in the percent of African-American residents in the islands in black and red lines in red, the gap widened. Again, a testament to how difficult and how insistent these principles of segregation work. And now look at this image. If you look at the image I shared with you before in the context of what I'm describing to you, it turns out that a system remarkably established 90 years ago may in part be a root cause of the disproportionate burden of COVID-19 deaths in communities of color in Chicago. I'm offering this to you as a model, as a partial explanation for what we've seen, not as the explanation. The intent is not to impugn any person or any entity, but the intent is to say structural racism is a phenomenon, and it may well be in play given what we've seen with COVID-19. And as an additional irony, if I leave my office this evening and get on the nearest commuter rail, it's the red line. The red line goes from Streeterville to the south side of Chicago. Isn't it ironic that it's called the red line? So let's continue. There's a glossary that I indicated I would share with you that addresses this intersectionality of racism, bias, and equity. The critical definition is a definition about racism. This is really important because so many people bristle when these discussions are held because it's so easy to take these statements as personal. Personal racism is what I described at the beginning, what I experienced as a young child growing up in the Deep South. Overt hatred just based on the way one person appears to another person between two individuals, an interpersonal conflict. Cultural racism is what we see in our media, our entertainment areas, sports and athletics, where we assume that there are behaviors that all align with one group and other behaviors with another group. But it's this institutional, systemic, structural racism that is so important because it's about what is the influence of the way systems are built that has a bearing on how life is experienced. I also want to give you this first-hand perspective from those early life experiences I described to you so you can know what racism feels like, because I understand the difficulty of trying to inculcate racism in a mindset if your life and living experiences haven't really dealt with this in first-hand perspective. As a child, racism makes you feel lost and afraid. As a young adult, racism leaves you on the outside looking in. As a young aspiring professional, racism makes you start at the back, work twice as hard for half as much. And as a mature adult, racism makes your soul grieve, and many of us have done a fair amount of grieving. What about addressing cause? Well, bias appears to be cause here, and cause is where we're heading in terms of this health inequity crisis. Think about what you see here. Do you see 4 logs of timber? Do you see 3? Think about here. What do you see? Do you see a frog or a horse? It's easy to see a frog sitting on a lily pad, but if you tilt your head to the right, you can see the horse's snout at about 11 o'clock. You can see the mane running from 3 o'clock to 9 o'clock. So obviously there is something that you have to adjust and adapt to based on what you see. What about now? Do you see a young woman with a distant gaze over her right shoulder? Or do you see an older woman with coarse features looking down on her bosom, looking down towards the ground? The question becomes, are these optical illusions or brain illusions? To make this more relevant, what do you see here? This is me surrounded by 800 of my peers at Northwestern, reflecting on 9 minutes and 30 seconds of silence for obvious reasons. What about here? This was a shooting about an hour and 50 minutes north in Kenosha, Wisconsin. What about here? This was an eruptive moment where a person ended up being killed at this moment. And another person's looking at a long amount of time incarcerated. What about here? These were eruptive episodes of civil unrest, violence, looting that happened in my own city that I love so much. And this was just abhorrent, but this was an experience. And what about here? Private citizens with the right to bear arms, obviously upset, fearful, concerned. There's a right of self-expression that has to be respected. And what about here? January 6, 2021. It bears no additional narrative. So how are you processing information? Sadness, despair? Did you see police brutality, violence, anarchy? Or did you see civil protests, freedom of speech, right to bear arms, social justice, Black Lives Matter? Did you think about equity? We all have neural networks that allow us to think fast, to be very responsive, or to be more cognitive, more deliberative, and think slow. This is archived in work by Daniel Kahneman, a Nobel Prize winner, who really tried to help us understand how people make decisions. Ultimately, what we're talking about is bias and how that informs so many decisions. And we need to appreciate that it's automatic, it's embedded in everyone, it operates in every decision we make, and that overwhelmingly the bias is in favor of white persons, men in our communities. And these data come from medical students. But here is the clinical interface. This is why this is so important in a healthcare context. You can see the caricature of the healthcare professional and the patient having an interface that is then uploaded with objective data. It's the interpretive eye. This is the critical moment. Is this an eye that is culturally aligned or culturally dissonant? If it's the latter, then stereotyping, prejudice, and bias creep in, and the decisions are not just. They're not inclined towards best outcome. But if the interpretive eye is influenced by an awareness and appreciation for differences, then perhaps the interventions are different. So then we get to this, again, high point of what I wanted to discuss with you today, the defining attribute of professionalism, and I think it's equity. What is that? Well, look at this cartoon. You can see what happens when everyone has equal access to a good or service, in this case, a game. What happens when we have equitable access to a good or service, where the access is adjusted according to the barrier or the impediment, but then there's the reality where one group has a highly privileged advantage and a bird's eye view that is unparalleled, while the reality for another group is that they're in a rut, can never emerge from that. That's the question of the day. What happens if all three of the caricatures are the same height? Equality, they all get the same support, but the barrier is different. And so access to the good service is different. But what is equity? This is a very important statement in this presentation. It's where the support, despite the fact that they're all the same, where the support is adjusted to overcome the barrier. That is a take-home point. So if we're thinking about professionalism, what's the characteristic set of attributes that define professionalism? And this is from the corporate lens. You can see in this wordle, professionalism really talks about mastery, accountability, integrity, competence, responsibility. None of us would take issue at all with this definition. What about the same wordle for medicine? Because here we see that equity is conspicuously absent. The same wordle in medicine, the words that you would expect to see: empathy, honesty, responsibility, disclosure, respect, compassion, the patient at the center. This clearly qualifies professionalism from a medical standpoint. But I want to leave this up for another moment, because what don't you see? You don't see equity. Not in the professional description of, the corporate description of professionalism, or the healthcare description of professionalism. So I think this reference is profound. The American Medical Association's Journal of Ethics, published in March of this year. How should health professionalism be defined to address health equity? I think this is the critical question of what I'm sharing with you today, and I think it intersects well with the overarching theme of this summit. Let's start with what the abstract says. Increasing focus on health equity is placing a spotlight on health professionals' roles. Recent public health crises, I don't need to articulate those, have renewed focus on racial and ethnic inequity and underscored that trust is foundational to public health and health professionalism. Organizational, system, and policy reform demand that professionalism be redefined in terms of its capacity to motivate equity in health professions, education, and clinical practice. So setting out a trajectory that what's been missing is this understanding and appreciation of the importance of health equity. It goes on to say that the LCME, we're just completing our every 8-year evaluation by the LCME, requires curricula, it means as a standard, There has to be recognition of the impact of disparities and a study of the potential methods to eliminate healthcare disparities. What about from the ACGME? It is specified that respect for patient autonomy is paramount. Responsiveness to patient needs that supersedes self-interest and recognizes diversity and accountability to patients, society, and the profession. And what about the American Board of Medical Specialists? I am a member of the ABIM, articulates medical professionals' three-part promise to acquire, maintain, and advance ethical values grounded in patients, in the public's interest, knowledge and technical skills, and interpersonal skills. What about equity in the profession? This statement from the AME argues that a more diverse student body and workforce is key to motivating equity in public health. It identifies and endorses that medical students with minoritized identities report more discrimination and mistreatment than white medical students. It makes clear Black people make up over 13% of the US population, yet only 4.8% of US physicians are Black, while 32% of the lower paid healthcare, and let me add, essential workers, those who had to come to work during the pandemic, regardless, are Black. Thus the exposure yet again. It makes the profound statement that millions of these essential health workers needed to continue to work, were required to continue to work despite very low pay and compromised safety. And then what about in medicine? I think this is really important. In medicine, an enduring privilege of membership in the profession that we enjoy has been professional self-regulation. Professionalism, if it's to be on exquisite display, should now require physicians to draw on their social status and cultural authority to press for healthcare worker diversity, inclusion, and equity. It is a statement that, again, is a take-with statement, and then makes reference to the Hippocratic Oath. How does the Hippocratic Oath end? We've all heard this before, that into whatsoever house I will enter, it shall be for the good of the sick, to the utmost of my power. And it closes with, if I keep this oath faithfully, may I enjoy my life and practice my art respected by all men and in all times. So how do we become more equitable? I've set out an argument for the cultural set points that created the inequities. I've set out an argument for a very clear example of what happens when health equity is not present, that is COVID-19. I've challenged our thinking to say the root cause of at least some of that health inequity in COVID-19 came from community inequity, driven by decisions made 90 years ago. I've given you definitions of intersectionality, of racism, bias, and equity, and then established, in this case, the hypothesis that equity should be a part of what defines who we are as professionals, whether it's in the corporate space, but particularly in the healthcare space, and uniquely in the space of medicine, echoing what's in our Hippocratic Oath. So here are the steps to how we can become persons who incorporate equity for the purpose of addressing racial inequities and reducing disparities. Number one, overcoming implicit biases. Consider a different perspective. Recognize that there may be more content, depth, substance present than was initially appreciated. Check your assumptions at the door. Be willing to think unconventionally. Step two, become an ally. What does an ally mean? Well, it's what comes after diversity and inclusion. It's called allyship, where you agree to work in solidarity with minoritized and marginalized groups of people. This is a leadership conference. You have the privilege to make that decision. And speaking of privilege, this is foundational in allyship, where a person of privilege seeks to operate in solidarity with a minoritized and marginalized group of people. Are you privileged? Go through the interrogatories. If you are speaking, me, planning, CMSS, attending, all of you in leadership, you're privileged. We all meet one or more of these interrogatories. So let me quickly tell you the 6 A's to becoming an ally, all built on the principle of Socrates. The secret of change is to focus all of your energy not on fighting the old, but on building the new. Number one, altruism. Can you be selfless? Number two, awareness. Socrates again, wisdom is knowing what you don't know. What about advocacy? I love this subtext, boosterism. Can you take up the cause of another and advocate on their behalf? What about appropriation? This is capital, this is time, this is your own brand equity. Can you make a commitment of resources to help another? What about accountability? Can you own this and say, it's on me to make a difference? Can you? That's a big statement. And in action, can you reject bigotry, misogyny, racism? Those are stand-up principles that leaders need to think about as we go forward. What's step 3? Can you serve as a champion of diversity? I want you to see this comment. Time to look in the mirror. This is from the editor of Science magazine, H. Holden Thorpe. And then science and scientists finally need to listen to and make space for people of color to lead laboratories that publish great science and produce influential scientists, run institutions and their scientific units to propel science, and other journals to promote structurally underfunded scientists in areas of science. And in the words of an African-American woman who is a recognized, highly regarded scientist, how much creativity are we leaving on the table? Because science repeatedly fails to come to terms with our narrowly defined processes and our limited ways of determining success. Think about that interrogatory. How much creativity are we leaving on the table? Are we being equitable in our decisions about who we mentor and bring forward as future scientists? And can we build an anti-racist culture? You know, the world has changed when the Journal of the American College of Cardiology, an overtly clinical journal, publishes this just weeks ago, building an anti-racist culture. It's in the recruitment, it's in the teaching, it's in the career promotion, it's in day-to-day activities, it's acting on a personal level. This is a way we can become more equitable when we think about what's involved in actually building an anti-racist culture. And if other speakers haven't given you a matrix to appreciate how we get to anti-racism, I offer this to you as a strategy. But what about diversity? Is that the solution? So many leaders spend so much effort targeting diversity and managing the metrics. But let me be very clear, it's not about representativeness. It's instead about excellence. It's about growth. It's about prosperity. Use diversity as a way to be better, not as a way to be accountable. Oftentimes we argue that the absence of diversity is because a pipeline isn't there. I'd rather think that's not the case. And I make this argument. These data from the AAMC are quite striking. Look at the percent faculty in medical schools on the horizontal axis and the percent matriculation of students on the vertical axis. Look at the slope of the curves. The greater the percent of senior faculty members that hold the rank of professor, correspondingly, the greater the percent matriculation. It really suggests a very compelling association. It's not causative, that's not proven, but it does argue that when there's diversity in leadership, then diversity metrics throughout the entity follow suit. And as this is a summit of leadership, it's very important for us to think about this as leaders. Do we look to our left shoulder, our right shoulder, and what diversity do we see? If we don't see diversity, I would argue that's your first action item. I put in print this bold approach, indicating that the deficit of physicians in medicine reflects inequities that happened in 1910 as a result of the Fluxman Report, when the minority-facing schools were almost completely eliminated, with the exception of 2. Now the number's up to 4. It arguably would be a bold strategy to create a 5th school, aligned with historically Black college and university, not because we're looking for a 100% populated cohort of underrepresented minorities, but because we're going to a culture, let me emphasize that, a culture that has a legacy of nurturing raw talent, piercing negative inertia, and illuminating arcs of success. I'll share with you a fair amount of information, fair amount of thought. I've tried to be provocative. I've hoped that you've felt something that moved you, either to the point of passion or to the point of concern. The point is that we all need to engage in an active thought process. And as we're engaged in this active thought process about the necessity to bring equity into the list of attributes that qualifies as professionalism, take to heart the words of Clayton Christensen, a famous lecturer at the Harvard School of Business, died about 1 year ago before COVID-19 really took off. He knew that his end was coming, and he said this is my final recommendation. Think about the metric by which your life will be judged, not by your accolades, but by the people you've helped, and make a resolution to live every day so that in the end, your life will be judged as success. I submit to my friends and colleagues and peers listening today that incorporating equity as a part of our professionalism is precisely a path towards accomplishing what is articulated here by Clayton Christensen. I really can't thank you enough for the opportunity to be a part of this meeting, and I turn the control back over to Dr. Bernstein and her colleagues. Thank you so much, Helen.
Oh, thank you so much, Dr. Clancy. Between your session and Dr. Lipson's session, you have given us lots and lots of food for thought. I wish we had a lot more time for Q&A. There was a question from Dr. Darla Moria, who you probably know from ACP, and she asked how you would actually make the organizations more accountable for professionalism in terms of their role in the medical profession. Any reflections there?
Absolutely, Dr. Moya, thank you for that question. We have to realize that systems, organizations are driven by three things: a mission, a leader, and a culture. And so it's not a secret of what needs to happen. If the will of the leader is to evolve a different organization and to bring equity into the front and center position for the characteristic trait of persons working in that organization, state it as a functional mission, endorse it as a strategic plan, and then execute it, because the way we change culture is when leaders say, we will become this, we will validate this, we will award it, and that's how it proceeds. But I think this in particular, Dr. Moore, is not a grassroots ground up program. This starts at the top with a brave leader that takes a bold position, knowing that there'll be some pushback, and then executes. So thank you for that question.
That's great. Actually, most of the comments were just how outstanding it was, as opposed to direct questions. I think you're absolutely right. I think a lot of people were moved. And I think this is one of those presentations, as I think as well, Dr. Lipson's presentation, where you kind of have to think and marinate on it a bit. So we will definitely, thank you so much for joining us today. And we will definitely come back with some questions that get generated through the rest of the time period. And again, just thank you for your leadership here. And thank you for inspiring us to think about equity as a metric of professionalism.